Hello. Today what we're going to talk about is microcirculation. What we have is we have the artery coming in like that, then you have the resistance arterioles diagrammatically, then we have capillaries, then we have the veins. So here's the artery, here's the capillaries, and here's the veins. And the blood flows this way. And what we're going to be focusing on is the capillary area. And we have pressure in, and pressure out, and that pressure gradient drives that blood flow. And what we would also focus on here is we have also lymphatics. And what we're focusing on is the capillaries. So we have a hydrostatic pressure that is pushing blood out of the capillaries. And what we have here is hydrostatic pressure will push fluid out of those capillaries. And then we'll have oncotic pressure that reabsorbs that fluid from the capillaries. And then there's a small amount of fluid that is not reabsorbed, and that small amount of fluid is taken up by the lymphatics. So essentially we have four different players that we're talking about here. We have the hydrostatic pressure, which forces fluid out of the capillaries. Then we have oncotic pressure, which reabsorbs water back into the capillaries. We have a very tiny amount of fluid that is not reabsorbed in the capillaries, goes into the interstitial space, and it's removed from that interstitial space by the lymphatics. So there are four different players that we're going to be talking about. The first one is the hydrostatic pressure here. And that hydrostatic pressure is a pressure in a confined space. And what that does, that pressure pushes fluid out of the capillaries. And that capillary pressure, of course, hydrostatic pressure in the capillaries, is always going to be higher than the pressure in the interstitial. Okay? However, if this hydrostatic pressure was the only player involved in microcirculation, we'd have fluid only leaving the blood. Okay? And we know that doesn't happen. So the second player that is important here is oncotic pressure. And that oncotic pressure is basically the cells and the proteins within the blood. And what those things do is that they help resorb water back into the capillaries. And it opposes that hydrostatic pressure. So we have filtration and reabsorption going on so that we don't have massive losses of fluid from the blood. These capillaries here are the most important part of the microcirculation. And what's important in the capillaries is how easily does that fluid leave the capillaries. So that depends on the different kinds of capillaries that you have. The majority are continuous, so they're relatively fixed barrier for fluid loss, and you tend not to get very large proteins leaving. And we have a reflection coefficient, which is a parameter that shows how easily fluid leaves from those capillaries. And the amount of fluid that can leave from the capillaries can be changed by several different things: inflammation, hypoxia, and burns. So we talked about hydrostatic pressure, oncotic pressure, and the capillaries. Now we're going to talk about the fourth player, which is that lymphatics. So what happens is that there's a small amount of fluid that's not reabsorbed in the capillaries, okay? About 5 to 10%, or 2 to 4 liters per day. And that small amount of fluid is taken up into the lymphatics. And that's based on the Starling's hypothesis, where under normal conditions, the amount of fluid leaving the arterial end of the capillary almost equals that to the fluid reabsorbed into the circulation. So that's just Starling's hypothesis. So basically almost all of the fluid filtered out is almost all reabsorbed, and a tiny amount is taken up by the lymphatics. So the lymphatics are very, very important in this microcirculation. They're typically not appreciated. The lymphatics also play a role in immune surveillance and protein and lipid delivery to the blood. So these lymphatics, they have pumping activity. And that pumping activity can be active. So in the larger vessels, they have muscles around them, and they actually they pump, okay? So you can have very, very high pressures within those larger lymphatic vessels. And actually that pumping activity within the lymphatics will increase if the interstitial or IF pressures increase. So basically it's a mechanism to keep those interstitial pressures relatively low. You also have passive pumping, and that's squeezing of the skeletal muscles in your calves, etc. Your respiration, causing changes in pressure and causing movement of lymphatics. And also in your gut, you also have gut movement causes movement of lymph. And the important point there is that you have one-way valves within the lymphatics. Those one-way valves allow unidirectional movement of that lymphatics. And in the interstitium, in the interstitial fluids, the lymphatics are basically have small open endings with very low pressure within them, because you have pumping essentially sucking fluid into the lymphatics. So the way that I view it is that the lymphatics are basically a vacuum cleaner sucking up any of this extra fluid that is left within the interstitial space. So what we have here is we have four players. We have the hydrostatic pressure, we have oncotic pressure, we have the capillaries, and we have the lymphatics. The hydrostatic pressure is basically the pressure difference between the pressure going in and the pressure out across those capillaries. That hydrostatic pressure forces liquid out. Okay, and if that was the only player, we'd just have fluid leaving the blood constantly. That would be terrible. But we also have oncotic pressures, shown in green, which causes reabsorption of fluid into the capillaries when those pressures are lower. The third one, we have capillaries in the yellow, and basically the amount of fluid that leaves the capillaries is basically a function of how easily the fluid can pass through the walls of the capillary, and that is the reflection coefficient, and it can be altered by inflammation, burns, and hypoxia. The last player that we have is lymphatics, and lymphatics is important related to the Starling's hypothesis, shown in the center, where normally, under normal conditions, fluid that leaves the arteriolar end is almost equal to fluid reabsorbed in the circulation. Okay. So there's a tiny amount of fluid that's not reabsorbed, 5 to 10%, and that's about 2 to 4 liters per day, and that's handled by the lymphatics. I view the lymphatics as a vacuum cleaner that basically remove all of these excess fluid that's not reabsorbed. So those are the four players there. Okay, so we talked about the four players. But let's focus in graphically on the hydrostatic pressure, oncotic pressure, and what we have with the capillary, across the capillary. So in this graph, we have pressures on the y-axis, and we have the capillary on the x. We have the arteriolar end, and we have the venular end. And what we have is we have a very steep drop in hydrostatic pressure, okay, down from the arteriolar end to the venular end of the capillary. It's a very steep hydrostatic pressure drop. Okay, so in this top graph, we talked about what happens in the capillaries with the hydrostatic pressure and the oncotic pressure. Let's look at what happens in the interstitial fluid itself. So what we have is we have an increase in oncotic pressure from the arteriolar end to the venular end of the capillary. And that's because you get water reabsorption, so those protein concentrations in that region of the interstitial fluid increase. And the hydrostatic pressure stays very low, -2, and constant. And that's because of those lymphatics. So that lymphatics remove all of that extra pressure, okay? Remove all of that extra fluid and keeping that pressure in the interstitial region relatively low. So we have what happens in the capillary, and we have what happens in the interstitial fluid with the oncotic and hydrostatic pressure. On this graph here, you can see predominantly that there's filtration. The hydrostatic pressure is greater than oncotic, and in the venular end, towards the venular end, the hydrostatic pressure is decreased and the oncotic pressure is higher, so you're going to have a reabsorption of fluid. In the interstitial fluid, you have oncotic pressure and hydrostatic pressure, but these are much lower than what you have in the capillary. So the major player for this microcirculation is the capillary, and the interstitial fluid only plays a role if you have problems, okay? It only contributes if there's problems where you change the pressures in the interstitial fluid. So now let's look and see how we can calculate the net filtration pressure, whether or not you're getting filtration or reabsorption over the entire length of that capillary, okay? So what you'll do is you have the N FP, which is the net filtration pressure. That's a pressure, very important. And just to simplify it, what we're going to do is we're going to take the hydrostatic pressure, shown here in red. So the hydrostatic pressures tend to be greater than the oncotic pressures in general. So the hydrostatic pressure minus the oncotic pressure, shown in green as tau. And what we're going to do for each of these different units, okay, is we're going to plug in the hydrostatic pressure for the capillary minus the hydrostatic pressure for the interstitial fluid. And then for the oncotic pressure, we're going to do the oncotic pressure for the capillary minus the oncotic pressure for the interstitial fluid, so capillary minus IF. And that's the same for both of these. Then what we also do is we throw in that reflection coefficient here right before that oncotic pressure. So that oncotic pressure can change depending on how permeable that capillary is. Okay, so we plug all of these values into this equation, and if we have a positive value, that means we have filtration. If we end up with a negative value, that means we have reabsorption, okay, when we use this equation. So there's another part of the equation that we have to introduce, and what we have there is the flux. So for the flux, what we do is we add in a constant. And what we do is that constant is basically the hydraulic constant and area. Okay, so all of that is involved within this flux. And basically you multiply the net filtration pressure by that specific constant. So essentially what you're going to be doing is you're going to be changing that net filtration pressure from a pressure to a flux of volume per minute. So what we have is we can calculate the net filtration pressure, and what that is the hydrostatic pressure minus the oncotic pressure. To change that pressure into a flux of volume that is filtrated, we basically plug a constant in front of this net filtration pressure equation. So when you're doing these calculations here, make sure that you pay attention to the reflection coefficient, which goes in front of the oncotic, and that hydraulic conductivity, which goes around. You multiply that whole net filtration pressure equation. So basically, you use the Starling's equation to find out the pressures, okay, over that whole capillary to see if there's filtration, which is positive net filtration pressure, or if you have reabsorption, which is a negative filtration pressure. So this equation takes into account what's happening in the capillary with oncotic and hydrostatic pressures, and also in the interstitial fluid with the oncotic and hydrostatic pressures. Okay, so that's that Starling equation there. Okay, so now we've talked about the microcirculation. Let's talk about what happens when you have problems with the microcirculation. That leads to edema. So basically, edema is when you have problems with filtration, reabsorption, or the lymphatics that leads to fluid accumulation in that interstitium. So you can have increased hydrostatic pressure, and that occurs with the hearts or the veins, okay, problems with the hearts or the veins. You have decreased oncotic pressure in the capillaries, so less reabsorption, okay. So, and that's typically proteins with albumin, and albumin is made in the liver. So with the liver, you can have malnutrition, so the liver says, hey, I'm not going to make any albumin. Or you can have liver failure, and then the liver cannot make enough albumin as needed. You can have problems with the kidney. So the kidney can filter out increased amounts of protein that cause that oncotic pressure. And that dysfunction will allow proteins larger than 60 kilodaltons to pass through and be filtered. And albumin is the majority of protein in the blood, and it's about 60 kilodaltons. So if you have problems in the kidney, you're going to be removing albumin. Also, in pregnancy, you can decrease your oncotic pressure in the capillaries because you have an increase in blood volume, and you're just going to dilute out those proteins. So you have increased hydrostatic pressure. You're going to be increasing the pushing out of fluid from the blood. If you decrease the oncotic pressure, you're going to reduce the reabsorption of that fluid back into the capillaries. Okay, so now let's talk about edema and focus in on the heart. Okay. When you think of heart failure, you have to think of it backing up. Okay, so it's not pumping out, so it's going to back up. The pressure is going to back up into the atria. Those pressures in the atria are going to back up into those veins. You're going to get increased pressure in the veins. You're going to get increased pressure in the capillaries. The most important part is that you increase that pressure in the capillaries, and it's backing up, okay, into the different regions. Okay, so we talked about what happens when you have problems with the heart pumping out. The blood backs up into the atria, then backs up into the veins, backs up in the capillary. You increase the hydrostatic pressure, and then you're going to increase filtration, and you're going to increase edema, okay, cause edema. So with heart failure, you have left-sided heart failure. The blood comes from the lungs, okay, from the pulmonary circulation will be affected. So the blood will back up into the lungs itself and eventually cause pulmonary hypertension. And then you'll have pulmonary edema. You have problems with gas exchange, problems with lung inflation. Okay, problems with lung inflation is going to have problems with breathing, dyspnea. In the right heart failure, shown by the R, the blood comes from the tissues, comes from the systemic circulation into the right heart. Okay, and then the problems with the right heart, you'll have backup into the tissues, and you get tissue edema. So you'll get problems with nutrient exchange in the tissues, infection such as cellulitis. Okay, you're not flushing the tissues as effectively, swelling due to the edema, and typically you have pitting edema in the ankles. So when you push into the skin, there'll be a pit remaining there for a short period of time. Okay, so we talked about heart failure, where you also have edema. Hypertension in the systemic or pulmonary system can also lead to problems with filtration, because you're going to increase the hydrostatic pressure. If we have liver failure, for example, we're going to increase the pressure in the hepatic portal system. Okay, and in severe cases, you get esophageal varices, okay, enlargement of the veins in the esophagus, and sometimes those can burst and cause bleeding through your mouth, so red blood coming out of your mouth. But in general, with liver failure, you can have increase in filtration into the abdominal cavity. You can have edema, and you can have an enlarged abdomen with abdominal ascites. You can also have lymphatic dysfunction. So these poor guys, the lymphatics, are typically ignored or forgotten or left out in the microcirculation. So we invite them to the party, and we don't give them much credit. But if you have impaired fluid removal from the interstitium, you're going to get edema. And this is typically called lymphedema, because the problem is due to the lymph, and it's due to damage or removal of the lymph nodes. So you can have removal of the lymph nodes with surgery, damage with radiation for cancer, such as breast cancer, or infection with parasites, filariasis. So you're going to get enlargement or edema in that specific region that's drained by that lymphatic system that's damaged. Okay, so we have edema, okay, problems with filtration, reabsorption of the lymph, or we have heart failure, hypertension, liver failure, or lymphatic dysfunctions.